So my topic will be about postoperative arrhythmia after pediatric cardiac surgery. So we'll start with introduction, then etiology of early postoperative arrhythmia after congenital cardiac surgery, pathophysiology of early postoperative arrhythmias, diagnostic evaluation, the usefulness of temporary epicardial pacing wires, and also the importance of atrial ECG. And a little bit, I will talk about late postoperative arrhythmias, and finally, to take a home message. So we'll start our lecture with a case, a 2-year-old boy who had tracheal of fallow repair and was hemodynamically stable. And 2 hours after surgery, he presented with tachyarrhythmias affecting his hemodynamics, and this is his ECG. At the end of presentation, we will discuss this ECG. And so think about it. So arrhythmia are well-known complications after congenital cardiac surgery. Although transient and treatable in most cases, they are a cause of substantial morbidity and mortality. In early postoperative period, hemodynamic fluctuations are common, making the patient unstable and may lead to low cardiac output syndrome and cardiac arrest unless treated and resolved in a timely fashion. Actually, those patients after congenital cardiac surgery, they are vulnerable patients. A lot of complex congenital heart, and also after cardiopulmonary bypass and ischemic time, the myocardium becomes vulnerable. So with any tachyarrhythmias or bradyarrhythmias, it leads to hemodynamic instability. Review of existing literature revealed an incidence of postoperative arrhythmia, early postoperative arrhythmia, ranging from 7.3 to 48% in some institutions. So it's actually a big incidence. Etiology of early postoperative arrhythmia related to myocardial incisions, cannulations, sutures close to the conduction system, cardiac dysfunction, electrolyte disturbances, catecholamine stimulation. So as many patients, they have infusion of catecholamines like adrenaline, noradrenaline, milrinone, acute changes in intracardiac pressure and volumes, cardiopulmonary bypass, related inflammations, ischemia, and deperfusion, residual hemodynamic impairment, pain, and anxiety. So just to summarize those factors, probably it may be preoperative factors like age of the patient. The smaller the age of the patient, the more risk for postoperative arrhythmia. Also, the smaller weight, the more risk for postoperative arrhythmias. Type of cardiac lesions, degree of cardiac dysfunction, comorbidities, and preoperative medications. For the operative factors like surgical techniques, cardiopulmonary bypass time, and cross-clamp time. The more cardiopulmonary bypass time and cross-clamp time, the more risk of postoperative arrhythmias. In the postoperative period, electrolyte disturbances, especially hypokalemia and hypomagnesemia. Inotropic support, most of the inotropic support, they increase the risk of postoperative arrhythmias. Residual hemodynamic impairment, acute changes in intracardiac pressure. All those factors leads to more risk for development of early postoperative arrhythmia. What is the mechanisms? It is the mechanism postoperative arrhythmia, like the mechanism of any arrhythmias, it may be related to abnormal automaticity, re-entry circuit, and triggered activity. The commonest arrhythmias with abnormal automaticity are junction ectopic tachycardia and ectopic atrial tachycardias. And for the re-entry circuit, some patients, like with epistine anomaly, they may have an accessory pathway, and this accessory pathway postoperative, because of the stress of surgery and the inotropic support, sympathomimetics leads to re-entry tachycardia. And some cases may have intra-atrial entrant tachycardias or ventricular tachycardias as a re-entry type of tachycardia. And by far the commonest is the junctional ectopic tachycardia. So the postoperative arrhythmias in those vulnerable patients, it leads to low cardiac output through fast heart rate, which decreases the diastolic filling, slow heart rate, as we all know that the cardiac output equal heart rate multiplied by stroke volume. So slow heart rate also leads to low cardiac output, irregular heart rate, and the most important thing is the loss of AV synchrony in some type of arrhythmias like junctional ectopic tachycardia. The loss of AV synchrony leads to also decreased cardiac output because loss of atrial kick, it's a big factor for low cardiac output, because normally the atrial kick contribute to 25% of the cardiac output. In many patients like tetralogy of Fallot, they have a stiff RV, so the atrial kick contribute to around 40% of the cardiac output because they have a diastolic dysfunction. So the atrial kick is very important. So loss of atrial kick with arrhythmias that leads to AV dysynchrony like JET leads to a significant low cardiac output. So the arrhythmia, early postoperative arrhythmia leading to low cardiac output, metabolic acidosis, myocardial depression, more inotropic support, and this leads to more arrhythmia. So actually, it's a vicious circle. So we have to recognize early postoperative arrhythmia immediately and manage it in a timely fashion in order to cut this vicious circle and improve the hemodynamics and low cardiac output syndrome. So what are types of early postoperative arrhythmias? We have tachycardias. The most common is the junctional ectopic tachycardia. Also, we can have the reentrant SVT, ectopic atrial tachycardia, VT, atrial flutter, and atrial fibrillation, although they are not common in postoperative cardiac surgery in pediatrics in the early period, but they can happen. Bradycardias like junctional rhythm, atrial rhythm, sinus node dysfunction, and heart block, extrasystole, PECs, and PVCs. So in the biggest series of studies, publications, they studied the early postoperative arrhythmia after congenital heart surgery. By far, the commonest arrhythmia is the junctional ectopic tachycardia. So the slides also show that high incidence of junctional ectopic tachycardia, and the second common is the postoperative complete heart block. So as I said before, immediate diagnosis is very important for proper management of postoperative arrhythmia. So a 12-lead ECG is very important and crucial to establish a template to compare QRS morphology if an arrhythmia develops or make a diagnosis of an existing arrhythmia. So the first thing is to do a 12-lead ECG. Also in the postoperative patients, usually those patients, they have an arterial line, central venous line or monitored by the invasive monitor. So checking the arterial pressure and waveform, looking for beat-to-beat variability in the pulse pressure can aid in detecting arrhythmias. Another thing, a regular biphasic atrial pulse contour on the bedside monitor is suggestive of AV synchrony, whereas a monophasic pulse contour, marked irregularity or presence of atrial cannon waves, provide evidence for a lack of appropriate AV synchrony. So it's very important to check for the arterial wave pulse and also the central venous pressure waves pulse. This is the typical room for the ICU with a lot of infusions, monitor, ECG machine, and echo machine, temporary pacemaker generator. So looking to the monitor here, the ECG in the left, this is a junctional rhythm, and on the right, the sinus. And just to see how the difference in the arterial pulse on the left with a junctional rhythm, and then improve the arterial wave pulse when returned to sinus rhythm. And also, as we see in the central venous pressure wave, the blue one on the lower part of the screen, here we notice monophasic canon waves. And then after return to sinus rhythm, this is a biphasic venous wave, which indicates adequate AV synchrony. So the first thing is to do an ECG to check the arterial and venous pressure waves, and then to do an echocardiography, which is very important to exclude a hemodynamic cause such as residual outflow obstruction, residual big VSDs, tamponade, or reduced cardiac functions, which can lead to a substrate for postoperative arrhythmias. So what are the common early postoperative arrhythmias? First is the junctional ectopic tachycardia. Actually, it's very common arrhythmias, and it is common to cause low cardiac output syndrome on those patients. It's considered to be the most common type of tachyarrhythmias seen during early postoperative care and encountered in 2 to 11.2% of children undergoing cardiac surgery. JET is a life-threatening tachyarrhythmia that happen particularly after procedures in the proximity to AV node, such as tetralogy of Fallot, perimembranous ventricular septal defect, and atrioventricular septal defect repair. It can also happen after arterial switch surgery and other surgical repair. The commonest are AV canal, VSD, and tetralogy of Fallot. It's an automatic focus firing in its own that may start spontaneously during surgery or immediately after surgery, most commonly during the first post-operative day. The heart rate is usually between 170 to 260 with narrow QRS complex and EV dissociation. But in many cases, post-tetralogy of Fallot repair, it comes with a wide complex tachycardia due to the presence of right bundle branch block. Occasionally, ventricular conduction and rhythm can be even faster than the atrial rhythm, and hence the atrial activation and P wave may come before, after, or buried within the QRS complex. Since the ventricular activation is independent and not related to atrial activation, most of the time atrial P wave is absent and cannot be seen in the regular ECG. And this is actually a challenge because most cases of JET, you cannot see a clear P wave. So I will discuss later the importance of doing an atrial ECG for accurate diagnosis of junctional ectopic tachycardia. Hemodynamically, and because of faster junctional rhythm, the ventricle cannot fill up normally during diastole, and this in addition to the lack of proper sequential synchronization between the atrial contraction and ventricular diastolic relaxation that permit proper ventricular diastolic filling and optimal cardiac output. As I told you before, the low cardiac output in JET has two mechanisms. The first is tachycardia, and the second is loss of AV synchrony and lack of atrial kick that contribute to 25 to 40% of the cardiac output. This is an example of a case of post-operative repair, and it has narrow just wide QRS tachycardia, a little bit wider QRS tachycardia with the P wave is not that clear in ECG, but this patient actually has an atrial ECG connected to V2, and the P wave is immediately comes on top of QRS. That's here. I will discuss later also the importance and how to use an atrial ECG in post-operative period. So just this is a schematic representation. This is during the sinus rhythm, and this is during the jet, which is an automatic focus firing at the AV node, and there is like an VE dissociation and lack of AV synchrony. So what is the proper management of junction ectopic tachycardia? As general guidelines for the management, first, you have to correct electrolyte disturbances and target serum magnesium level between 1.3 and 1.4, 1.5, and target potassium have to be between 4 and 4.5, not less than 4. Treat fever and maintain core temperature initially at 35 degrees centigrade because jet is very sensitive to higher temperature. Minimize inotropic support as much as possible, especially adrenaline. Correct hypoxia, acidosis, and maintain good preload. Correct anemia and target hemoglobin level between 12 and 14. Optimize analgesia and sedation, and start the dexamethasone, which is Presidex, which is actually a very important drug in control of postoperative jet, with a loading dose of 0.1 milligram per kg, followed by infusion of 0.5 to 0.7 mic per kg per hour. So this is the first step management or the general guidelines. If the patient is hemodynamically unstable, start loading dose of amiodarone, 5 milligram per kg over 2 hours, followed by continuous infusion of 10 to 20 milligram per kg per day for another 48 hours. The important thing is to give a loading cortisone over 2 hours at least, because it's have a a negative inotropic effect. So you have to give it over a longer time. Then how to restore the AV synchrony in cases of jet? First thing, if we attain heart rate control, we can do atrial pacing higher than the jet rate after jet rate is successively reduced by medications, as addition of atrial systole to the ventricular filling will augment the cardiac output. Atrial pacing alone may be associated with long PR interval or even Wenckebach due to the effect of trauma, edema, drugs, and hypothermia on the AV node. So in this case, we'll use the DDD mode, the AV sequential pacing mode, either DDI or DDD. The third thing is to use what's called R-wave synchronized atrial pacing, which actually this mode we don't use it a lot, but we can use it if we fail to decrease the rate and we fail to use the atrial pacing or AV sequential pacing. It's called reverse sequential pacing, where dual chamber pacemaker with atrial and ventricular pacing temporary wires are connected to pacer box in a reverse fashion. Atrial lead in ventricular channel and vice versa, with increased AV delay. The reverse ventricular and atrial wires leads target better synchronization through attempts of ventricular sensing and atrial pacing. The aim of this measure is to maintain stable hemodynamics by recruiting atrial CAC with sequential pacing while antiarrhythmic medication is continued as a bridge until tachycardia is controlled. In very resistant cases, we can use an ECMO support. So just to explain what is the reverse sequential pacing or R-wave synchronized atrial pacing, simply we would just connect the ventricular wires to the atrial input and the atrial wires to the ventricular output in the temporary pacemaker generator. So it's actually the ventricle is tensed and then gives the atrial pacing just before the next QRS. The thing that we have to prolong the AV delay, which is actually, it's a VA delay, not an AV delay. By this, we can attain atrioventricular synchrony. As we see here in this diagram, this is an R wave synchronized atrial pacing. As we see here, the P wave comes immediately before the QRS. Then after we stop, and this is the jet. And as we see, the change in the hemodynamics in the arterial pulse wave, and also the change in the CVP from the AV synchrony with biphasic wave to a canon or a regular wave on the right side. Sorry. So this is to summarize how to manage a case of jet. We have to check for any tamponade, check electrolytes, check evidence flow cardiac output, perform a 12-lead ECG with an atrial wire. If it's confirmed jet, you have to give a bolus analgesia, sedation, and cool the core temperature to 35, 36, reduce inotropic support, monitor for evidence of low cardiac output, echocardiography to exclude any surgical cause like RVT obstruction, tamponade, residual VSD. Still, jet is ongoing. We have to call the PICU consultant to inform that the cardiologist and cardiac surgeon. If heart rate is less than 170, do a trial of atrial or DDD pacing. If the patient is intubated, we can give vancomycin and cool the core temperature to 34, 35 degrees, and give then amiodarone, as I said before, a loading dose of 5 mg per kg over 2 hours, and a maintenance of 5 to 15 mg per kg per minute. And in resistance cases, we can consider ECMO support. So the second ectopic tachycardia that may happen after congenital heart surgery is the atrial tachycardia. Postoperative atrial tachycardia arises about 8% of children 8 to 14 days after congenital heart repair. Atrial ectopic tachycardia carries the potential for significant hemodynamic compromise and is associated with a 3 times higher mortality rate in infant undergoing cardiac surgery. Several risk factors have been identified in children and infants, including neonatal age, low body weight, hypokalemia, long cardiopulmonary bypass, and inotropic support. Common in transposition of great arteries, total anomalous pulmonary venous return repair, interstage univentricular physiology repair, and heterotaxy syndrome. So this is an example of ectopic atrial tachycardia in an infant post-arterial switch surgery. As we see, the axis of the P wave, it's negative in the inferior leads. And also another common thing is the sinus tachycardia, which can happen in many cases because of stress of surgery, inotropic support. So don't forget sinus tachycardia. Atrial flutter can also happen. It's not that common, but it can happen in the early postoperative period. And the management of atrial flutter is synchronized cardioversion. Also, we can use an atrial wires to overdrive if the cycle is not that short. And also AVRT and EVNRT can happen if the patient has an accessory pathway and not treated before, and can express itself in the post-operative because of stress of surgery and inotropic support. And also we can use the atrial wire to overdrive the circuit and stop the tachycardia. If not, we can use adenos. Atrial fibrillation also can happen. VT In some cases, also VT, but we have to look if there is any hemodynamic residual lesions, any depressed functions, electrolyte disturbance. We have to look for those cases, and we have to manage it immediately with cardioversion. PVCs is very common, and also PECs. And usually you don't manage those arrhythmias just to check for electrolytes and decreasing inotropic support, and check also for the central line. Sometimes the central line can touch the heart, the atrium, and causes some PECs. So we have to correct all those things, but usually it doesn't cause any hemodynamic instability and just correction of electrolyte disturbance. Bradyarrhythmias in postoperative period. As I told before, junctional rhythm, atrial rhythm, sinus node dysfunction, and also heart block. So a heart block can be first-degree heart block, and for those patients, we don't do anything, just to observe. Sometimes they have some edema in the postoperative period, and then it resolves. Second degree, either MOPS type 1, MOPS type 2. And third degree heart block. With AV dissociation. For the cases with a postoperative complete heart block, we have to start immediately pacing with external pacing wires. It's preferably to have an atrial and ventricular wires and to do sequential pacing, DDD pacing, as I told before, to improve the cardiac output. But if there is no atrial pacing, we will use the VVI mode. And those patients, if the AV conduction is not regained after you have to do a permanent pacemaker after 9 days post-operative. So now we have to discuss the importance of and how to use the temporary epicardial pacing wires. Temporary pacemaker is important in the management of arrhythmia after cardiac surgery, and it's life-saving in cases of bradyarrhythmias. The presence of atrial and ventricular pacing wires can help not only in arrhythmia management, but also in diagnosing certain types of arrhythmia by performing epicardial atrial electrogram. In many institutions, or it should be the preferred way of management is to have 2 atrial wire and 2 ventricular wires. But some institutions, they do only ventricular wire only, but this is not good practice. So all patients having a congenital heart surgery, they should come out from the OR with an atrial pacing wires and ventricular temporary pacing wires. So as we see in this schematic representation, we have 2 atrial pacing wires. Usually it comes at the right side of the patients, and 2 ventricular from the RV surface coming on the left side of the patients, and this is the external generators. So how to do an atrial ECG? The small amplitude atrial signals may make rhythm discrimination difficult or impossible. As I told before, in our case in the beginning, we cannot see actual P wave or occasional P wave. So it's very important to clarify the P wave in order to identify the type of arrhythmia. So the American Heart Association practice guidelines recommend adapting a 12-lead electrocardiogram to visualize an atrial signals using temporary atrial epicardial leads for the improvement of diagnostic accuracy. The P wave is accentuated and magnified and appears as a sharp spike, which can be easily visualized and can be identified with its exact position, whether before, within, or after QRS complex. So we, during doing the ECG, will connect the atrial wire either to V1 or V2. So the atrial activity will appear like a sharp spike. This is the surface P wave, the normal P wave, and this is the atrial signal or the atrial electrogram, which appears as a sharp signal like that in the middle of this paper. So just to show you how to do an atrial ECG, this is a baby postoperative with two atrial wires here on the right side, coming from the right side of the chest, and this is two ventricular wire. So we connect the ECG, either V1 or V2, to this alligator clamp, and then put the temporary atrial wire in this alligator clamp like this. We're connecting the temporary atrial wire, which is coming from the right side of the patient, to this alligator clamp, which is connected to V1 or V2. Here in this, it's connected to V2. As we see here in the screen of ECG, this is the sharp spikes, which is representing the atrial activity. This is how to do an atrial ECG, which is actually very important for diagnosis of postoperative arrhythmias. So the atrial wires have a diagnostic and therapeutic value. So for diagnostic purpose, it differentiates junctional tachycardia from supraventricular tachycardia and sinus tachycardia. In junctional tachycardia, the P wave are either superimposed on the R wave or dissociated from the R waves, as we saw before. Atrial ECG may also be useful in differentiating various degrees of heart block and sinus node dysfunction. In heart block, the atrial rate is generally faster than the ventricular rate, as opposed to sinus node dysfunction, where the reverse holds true. So this is an example of JET and doing an atrial ECG on V2. As we see here, this is in V2, there is a sharp spikes which comes on top of QRS. This is because some JET comes with the P just on top of QRS. This is another example of JET with the retrograde P wave. As we see here, the atrial ECG in V2. This is a sharp spike. This is represent a retrograde P wave, which is immediately close to the QRS with one-to-one conduction. And as we see in the rest of ECG, we cannot see a P wave. So the importance of atrial ECG is very important because it clearly shows the atrial activity, and it shows also the relation of the atrial activity to the ventricular activity. So this is another example of JET. And here, if we see the V2 atrial ECG, we see like VA dissociation. So this is an example of postoperative sinus tachycardia. We're doing an atrial ECG. As we see here, this is the atrial activity with the sharp spikes in V2 just before the QRS, but there is some PR interval here, a short PR interval because of sinus tachycardia, but this is clearly identify the P wave. And this is an example also of postoperative atrial flutter. And if we see here the atrial ECG in V1, we see like a 2-to-1 flutter. This is atrial activity, so a 2-to-1 flutter. In V1, the atrial ECG is connected to V1. So what is the therapeutic value of atrial wires? Terminations of tachycardia using temporary overdrive pacing can be an effective mean of terminating re-entry tachycardias, such as atrial flutter, paroxysmal supraventricular tachycardias. As I told before, restoration of AV synchrony in cases of JET, either by atrial pacing higher than the JET rate after JET rate is successively reduced by medications. As the addition of atrial systole to the ventricular filling will augment the cardiac output. Atrial pacing alone may be associated with long PR interval, or even Wenkebach due to effect of trauma, edema, drugs, and hypothermia on the EV node. For that, we use the AV sequential pacing using DDD or DDI mode. If not, we can use the R wave synchronized atrial pacing, as I told before, or a reverse sequential pacing.
Why is it?
So another important new modalities for monitoring of those patients is use the AtriAmp or atrial ECG continuous monitoring. This is actually a new modality for monitoring of postoperative patients using this type of cable. This cable has a slot for the temporary wires and another one for the external pacemaker generator cable. And this is for the ECG lead monitor or connection cable of the ECG monitor. With that, we can continuously monitor the atrial activity using this cable. And actually, in addition to monitoring, we can use the atrial pacemaker wire as a pacing, because the pacemaker generator also connected at this port. This is an example of an atrial ECG using the AtriAmp. This is clearly identify the P wave as a short signal. And this is also an example of a patient who had narrow-KRS tachycardia. And actually, on the usual monitor, we cannot identify what this type of arrhythmia, but using the atrial electrograms, we see it's 2-to-1 flutter. As we see here, this is an atrial spikes, and this is, so it's 2A for HV, so it's 2-to-1 flutter. So back to our case, which is a 2-year-old boy with tetralogy of fallot repair, underwent total repair, was hemodynamically stable, and 2 hours after surgery, he presented with tachyarrhythmias affecting his hemodynamics, his 12-lead ECG. As we see here, there is no clear P wave. After we do an atrial ECG, we see here this is a spikes of the P wave and dissociated from the ventricle, so there is a VA dissociation. So our diagnosis is junctional ectopic tachycardias. So we reduce the rate using amiodarone infusion, using the JET protocol, as I told you before. So resume of the AV synchrony, we did atrial overdrive and the pacing. A patient hemodynamics improved and he's back to sinus rhythm after 48 hours. And this is when we decrease his rate, we succeed to do atrial pacing. As we see, this is the atrial pacing to restore the AV synchrony, which actually improve his hemodynamics a lot. And we succeeded to break the cycle or the vicious circle of hemodynamic instability. So just we'll mention briefly points about late postoperative arrhythmias, especially in some cases. First, the case is post-Senning or mustard operation, which is atrial switch operations. As we know that the cases with the TGA, the standard of surgical management for them is an arterial switch operation. But some patients, they may present in as a late presenter after like 1.5 months of life. And in those patients, the LV becomes non-switchable because it's facing the pulmonary circulation, and the pulmonary circulation, pulmonary pressure drops significantly after first month of life. So the LV becomes non-switchable. So the surgical option for those patients to do a Senning or mustard procedures or atrial switch procedures. So the surgeon bring the SVC and IVC and baffle it to the mitral valve and the pulmonary veins and baffle it to the tricuspid valve. So actually, there is a distortion of the normal atrial anatomy. We called it systemic venous atrium, which carry the SVC and IVC to the mitral valve, and pulmonary venous atrium, which carry the pulmonary veins to the tricuspid valve. Those patients usually in the second or third decades of life, they present with many types of arrhythmias, and the commonest is the intraatrial reentrant tachycardias. And for those patients, in order to do ablation for those patients, we have to do angiography and puncture through the baffle from the systemic venous atrium to the pulmonary venous atrium, because the cavo-tricuspid isthmus usually will be in the pulmonary venous atrium and part in the systemic venous atrium. So they have to go with transeptal and puncture through this baffle to reach the pulmonary venous atrium. It's advisable to use either a TEE or intracardiac echo. Like in this images, it's a use of intracardiac echo to guide transeptal puncture of the systemic venous baffle to reach the pulmonary venous atrium. This is the 3D mapping showing here the pulmonary venous atrium and systemic venous atrium in a case of post-thinning. Another challenging cases, the cases with a single ventricle that have an extracardiac fontan anastomosis. As we know, the fontan, it brings the IVC with an extracardiac vascular tube through the right pulmonary artery. So that in order to, if this patient presents with arrhythmia, usually they present also with like an atrial arrhythmias, atrial flutters, intraatrial tachycardias. So in order to reach intracardiac, you have to puncture the fontan baffle into the heart. And this is the commonest site that we can puncture the fontan and going into the heart for ablation of arrhythmias. We have to do a CT, and if we have an intracardiac echo, it's very important and can guide the procedure safely. The third thing is post-operative tetralogy of Fallot or late arrhythmia. The important thing is the ventricular tachycardias, and those are the sites or the isthmus that can trigger the ventricular tachycardia, either in the site of RVUT patch, around the pulmonary valve, at the site of the VSD patch. These are the sites that can present with ventricular tachycardias. And nowadays, in many cases, we can do transcutaneous pulmonary valve implantation, but usually we have to rule out any arrhythmias on those patients before pulmonary valve implantation, because if we put a valve here, which is usually a stented valve in the RVUT, and this patient having a ventricular tachycardia, it will be very difficult to ablate after valve implantation. So it's advisable to have an EP study for those patients before valve implantation, just to make sure that there is no trigger for ventricular tachycardia before doing valve implantations. So take-home message: post-operative arrhythmias are common after cardiac surgery and may result in increased morbidity and mortality. Early recognition and prompt management of post-operative arrhythmias is very important and leads to recovery of ventricular function. Temporary epicardial pacing wires for atrium and ventricle are crucial after open heart surgery and can be used for diagnosis and therapy to restore AV synchrony. Atrial ECG is an important tool for accurate diagnosis of early post-operative arrhythmia, and recently continuous atrial ECG monitor using AtriAmp is very useful in those patients. Thank you.